Good evening and welcome to Doctors on Call. I'm Dr. Ray Christensen, faculty member from the Department of Family Medicine and Biobehavioral Health at the University of Minnesota Medical School Duluth campus, and a family medicine physician at Gateway Family Health Clinic, Moose Lake, Minnesota. I'm your host for our program tonight on men's health and kidney stones. Please remember the success of this program is very dependent on you, the viewer. So be sure that you call in your questions or email them to ask@wdsc.org. The telephone numbers can be found at the bottom of your screen. Our panelists this evening include Dr. Tolga Hanhan, a family medicine physician with St. Luke's Lakeview Medical Clinic, Two Harbors, and Dr. Benjamin Marsh, urologist with Essentia Health. Our medical students answering the phones tonight are Melissa Edgar from Casson, Minnesota, Michael Gutman from Marshall, Minnesota, and Shane Johansson from Austin, Minnesota. And now on to tonight's program, Men's Health and Kidney Stones. Well, good evening.
Good evening.
Tolga, tell us a little bit about your practice.
I'm a family medicine doctor up at Lakeview in Two Harbors, Minnesota. It's pretty broad spectrum. We have a small community hospital up there and a clinic as well. But it's fairly typical, I think, for a lot of rural Minnesota communities.
And Dr. Marsh, you practice over at Essentia. Can you tell us a little bit about your practice and what you do?
Sure. I'm a urologist at Essentia. I practice general urology, so it's a little bit of everything. I treat men, women, and even some children. Most common conditions I treat are kidney stones, enlarged prostate, a lot of urologic cancers such as prostate cancer, bladder cancer, kidney cancer.
Do you basically stay in Duluth, or do you visit some of your outstate sites?
I do outreach in Moose Lake, actually.
Oh, good for you.
Yep, twice a month.
Very good.
Mm-hmm.
Tolga, we talked a little earlier. I think we should start out maybe just discussing what's men's health, and what, at your office, what do you tell me if I come in for a preventive exam, or whatever those exams are? What would you tell a man about men's health?
Yeah, well, I think when we think about men's health, we'll get into the specifics of things that are unique to men today, but what is good for women is also good for men, and the number one killer of men's continues to be cardiovascular problems, heart attack, etc., and heart disease. And so when I think about men's health, first and foremost, it all comes back to living healthy. So exercise, good healthy diet, and trying to avoid some preventable conditions such as diabetes, etc.
Dr. Marsh, from a urologist standpoint, do you want to weigh in on this also?
Sure. So from my perspective, probably the most common things that I'm talking to men about in this topic would be making sure they're up to date on the recommended screening tests such as PSA screening, prostate exams, and also just talking about their voiding habits and erectile function and things like that, topics that men oftentimes need a little coaxing to discuss, I would say.
So you opened it up, PSA and rectal exams. We've been going through kind of a lot of whipsawing back and forth as to what we should do as physicians. What's the current status and what are your recommendations?
Yeah, as you mentioned, this is kind of a controversial topic, and for a while there was a recommendation to stop screening for prostate cancer with PSA testing, but that decision was reversed in recent years, and that's how I practice as well. So I do recommend that my patients get an annual PSA screening as well as a rectal exam to check their prostate. Yeah.
Tolga, do you kind of follow those same guidelines in your practice?
Yeah, we start thinking about prostate health, I think in your 50s. The current recommendation is to consider screening between ages 55 and 70. And so, yeah, we'll talk about risks and benefits of screening. Most men would like a PSA test. It's non-invasive, it's a blood study. And if there's a high-grade prostate cancer, typically it's going to show up in the blood.
What are the usual complaints of men in your office when they come in specific, now we're talking kidneys and men's health, so prostate, bladder, genitalia. What are the things that usually they complain about?
Yeah, most men, if they're going to complain about conditions unique to being a man, would include some urinary complaints. As we age, many of us get a larger prostate, and so what happens there? Well, prostate is an organ which is in the outlet of our urinary tract, or affects the outlet of our urinary tract, so urine can get backed up. So when that happens, you might feel like you have to urinate more often. You might feel like you don't empty your bladder very well. Some of my patients with large prostates will tell me in social situations, one of the first things they do is find the bathroom because they want to know where it is because they have to get there quickly.
Dr. Marsh, your thoughts on this?
Yeah, as Tolga mentioned, the common things that I hear are weak stream, frequent urination, getting up a lot at night. I often tell guys that the prostate kind of sits at the base of the bladder like an orange with a straw through it. And as they get older, the pulp of that orange continues to grow and kind of pushes in on the straw, can cause obstruction, which leads to all these symptoms that Tolga mentioned.
There's a question here. We talked earlier about going to kidney stones and talking about kidney stones a little bit. Tolga, and you and I talked briefly before. What are kidney stones, and you want to give us a little background of why they form?
Sure. Kidney stones can form anywhere basically in the urinary tract. They tend to form in the kidney itself, but they can be found anywhere in the urinary tract. They tend to be, most of them, some numbers I've seen is about 80% of them are made of a component called calcium oxalate. And they do, it's very pertinent to men's health as well because it is predominant in men. There's about a 1.3 to 1 ratio of men versus women, but women, of course, can get kidney stones as well. And then, as you might imagine, as a stone gets caught in your urinary tract, it can be quite painful. The smooth muscles of the urinary system can contract and cause a lot of pain. And some people are very prone to them. Sometimes they get so big they have to be removed by urologists.
So, Dr. Marsh, is there a diet, or what can I do to avoid getting them?
Yeah, so the most common thing that I tell my patients is that stones tend to form in more concentrated urine, and that if you're going to do one thing, making your urine more dilute by increasing your fluid intake and urine volume is the biggest thing that you can do. So I tell my patients to shoot for about 2.5 liters of urine output per day. So to make that much urine, you have to drink at least that much fluid. So I tell them to think about like a 2-liter bottle of soda, hopefully drinking water or something a little bit healthier than soda. But
so come on, guys, you got this little old man that's having trouble emptying his bladder now. How does this work?
Yeah, I'm sympathetic. We also have occupational risk for kidney stones as well. For people who can't urinate very frequently, if you're a cab driver, that's very difficult. Surgeons,
yeah.
Classroom teachers are all. That can be tough. That can be a big ask to drink that much water. There's some other smaller things that you can do. Avoiding salt also helps. You're less likely to put calcium in your urine. There's a list of oxalate-rich foods that you can try to avoid, although if you look at the list, there's a lot of delicious stuff on there, a lot of nuts, a lot of chocolate, a lot of actually healthy foods. And so I do tell my patients, know that list, but if you're going to eat something from it, wash it down with some calcium. Dietary calcium is generally considered a good thing, and if you can get that calcium to attach that oxalate in the GI tract, it's less likely to happen in your urinary tract.
Does alcohol help?
Funnily enough, the research shows that almost any type of fluid you drink, including wine, beer, and liquor, is going to increase your urine volume and decrease the incidence of kidney stones. I generally don't recommend that to my patients, but if I'm being honest, yeah, it does.
might make passing the stone a little better too.
Yeah.
I don't know why it has to hurt so bad. If someone gets a kidney stone, what are the chances they're going to get another?
Very good, unfortunately. So I think the latest data I saw that says that the general population, there's about a 10% incidence of kidney stones in the general population. Actually, that's the old data. That number has been increasing. I think it's now up to 15% or maybe higher. And I think it's about a 50% chance that if you have one stone, you're going to get another one down the line.
Wow. What size kidney stone will no longer pass on its own? I get the question right here.
Yeah, so I do a simple calculation typically, which is the size of the stone measured in millimeters. Maybe I'm getting too complicated. So basically a 10 millimeter stone has about a 0% chance of passing. A 9 millimeter stone has a 10% chance of passing.
Oof.
Down to a 5 millimeter stone has a 50% chance of passing. So, and you can extrapolate that up and down.
And once it passes through the ureter, it's still got to come out through the urethra too.
Right. Actually, I usually tell my patients that when the stone is up in the kidney, you generally don't feel it. And the same thing is true when it gets to the bladder. When it's in the ureter, that's where all the pain comes into play. And once it gets into the bladder, you're home free. It's actually, the diameter of the urethra is so much larger than the ureter that most patients don't even realize that they're passing the stone once it gets into the bladder.
So if we have a stone that's lodged up in the kidney, what do you do? Do we need to get the stone out? Can you live with the stone?
That's a good question. So depending on the size of the stone and if the patient has other issues, like some stones can be colonized with bacteria resulting in urinary tract infections. As long as something like that isn't present, yeah, you can live with the stone. Oftentimes I'll have patients come back on a yearly basis with something like an x-ray to make sure the stone isn't growing. If that was the case, then we might attack it sooner rather than later. I definitely have some patients, though, that either for personal reasons or even professional reasons, such as airline pilots, aren't allowed to fly if they have stones in their kidney. So they might want to, again, go after these stones sooner rather than later.
And I missed, can you go up and grab them, or do you lithotripsy, or what kind of things do you do?
That's the most common way they're treated nowadays, is ureteroscopically, which basically means with the patient asleep in the operating room, going in with a small camera through the urethra into the bladder and up into the kidney, and using a laser to break up the stone and take the pieces out. Shockwave lithotripsy is another option, so using shockwaves to break up the stone from outside the patient's body. That's becoming, I would say, less common as our technology with ureteroscopes gets better and better and smaller and smaller.
I haven't seen the lithotripsy for a long time.
Mm-hmm.
Tolga, are there certain ethnic groups that are at higher risk for developing kidney stones?
I don't know the answer to that question. Do you know?
Not to my knowledge, actually. I'm not sure. It is based a lot on diet, and so there may be some ethnic groups that their diet contributes to a larger incidence of stone formation, but I'm not sure off the top of my head.
At what age should men begin to have their prostate exams? We didn't go there. We just talked about men's health, but at what age would you start doing prostate exams, and then how often? So Tolga, in your practice?
Yeah, my practice is a different patient population than Dr. Marsh's, of course. He sees a lot, probably more people with prostate problems. I start checking prostates when people start having complaints. And for most people, that's probably in their 50s. And then as part of cancer screening, it can be considered as well. I think for a while, actually, it was pretty common as a way to kind of screen for cancers. But now that the blood studies are so good, I don't think that is done routinely quite as much.
Yeah, Tolga mentioned 55 as being a common age to start screening. There's also a recommendation to start as early as 45 if you have a family history of prostate cancer or if you're African American. So
you just brought up another topic. So we got the PSA and we got the digital rectal exam.
Mm-hmm.
Are they both important, or is it just the PSA we should worry about?
I think the PSA is a little bit more what we would call sensitive. And I think rectal exams can vary amongst the experience of even the doctor of how many they're doing, for example. This is an interesting question. How often would a prostate cancer show up with a negative PSA?
Yeah, it's very rare. So I put a lot more stock into the PSA personally. The rectal exam is probably more important for something such as staging, for getting a feel for if there is an obvious prostate cancer present. Is it invasive into neighboring structures like the rectum? But in terms of just detecting a prostate cancer, it's very rare, like 1% to 2% would be found on a rectal exam alone, but have a normal PSA level.
So then the other question that comes with this is you're doing a rectal exam for BPH, benign prostatic hypertrophy, big prostate.
Mm-hmm.
Does the size of the prostate on rectal exam equate with the symptoms?
Oftentimes, yes. But not necessarily, is the hedging answer there. That there can definitely be patients who have a very enlarged prostate on imaging tests or on rectal exam, but have very minimal to no symptoms whatsoever. And I think it has to do with more the configuration of the gland itself, and whether the gland is more obstructing or not, rather than just the absolute size.
Ben, do you want to talk a little bit about sponge kidneys? I don't know anything about sponge kidneys.
So medullary sponge kidney is a condition that can be associated with kidney stones, and specifically a condition called nephrocalcinosis, basically where the patient makes a large volume of stones infrequently. And these are usually calcium phosphate stones. And so basically it's a congenital condition, so they're born with it. And for whatever reason, the metabolics of that type of kidney predispose them to making more stones. And it gets kind of complex. But yeah, oftentimes these patients can have recurrent stones over many, many years.
And that was a female patient that called. Thank you.
Mm-hmm.
It brings back, I remember now a little more. Thank you. Tolga, this is kind of down your line a little bit. So should someone in their 60s see an internist rather than primary care provider for their yearly exam? So you want to correct what all's going on with that?
Yeah, so the word internist essentially refers to a specialty of medicine called internal medicine. Internal medicine is essentially medicine for adults and non-pregnant women. And family medicine, which is my specialty, is also for adults, but we also see kids as well, and some family medicine doctors will deliver babies and such. And so I think in terms of the question, if your provider is comfortable giving care to an adult, I think that's great. They'll be aware of these recommendations.
And an internist is a primary care physician also.
That's right, yep.
So, yep. Are there any drawbacks to taking furosemide or other diuretics for blood pressure? And I'm thinking kidneys, and so I'm bringing into the kidney.
From my perspective, oftentimes I see patients who are on Lasix or furosemide, and specifically that can increase their urine volume quite a bit. So if they do have existing prostate or bladder problems, that can exacerbate them quite a bit. But in terms of management of blood pressure or other issues, that's a little bit out of my realm of expertise.
Yeah, hydrochlorothiazide actually can prevent kidney stones. I mean, there's drawbacks to any medication, and one of them is regular lab monitoring for anybody on any type of diuretic.
You said it before, I heard it, but I want you to re-say it. Do men get kidney stones more than females? And I think you gave a number.
They do. The last numbers I looked at is men were about 30% more likely to get kidney stones. I believe that figure used to be something like 2 to 1, in other words, 50% more likely. But women are sadly closing that gap. I don't think it's a gap that women want to close. But women are getting more and more kidney stones for reasons we don't understand.
Gleason Scores.
Mm-hmm.
Can you give us a primer on Gleason Scores?
Yeah, so this is used in the setting of prostate cancer, specifically when patients have undergone a biopsy of their prostate. We look at the tissue under the microscope and give it a score based on kind of how ugly the cells look, the uglier being more aggressive, and a higher Gleason score. It's named for Dr. Gleason, who was a pathologist actually at the Minneapolis VA many years ago. And so this was the primary tool that we use in assigning prostate cancer to a different risk group, such as low, intermediate, or high risk, is mostly based on this Gleason score.
Speak a little bit about the lonely old foreskin. Just because I see quite a few older men that don't take proper care of things, and we get into trouble with phimosis or tightness at the end. Any suggestions or thoughts?
I mean, beyond basic hygiene and keeping things clean, and there's not a whole lot. I sometimes do see patients who are older and maybe have some issues like dementia and have trouble caring for themselves, and that can be a problem sometimes. But again, beyond basic hygiene recommendations, I wouldn't have a whole lot.
Just a quick tour a little further up, because we're on men's health. Somewhere between 3 and 5% of breast cancer is male, right?
That's right. I know it was less than 5%.
When should men be checked?
I mean, that's a good question. I don't think there's a specific recommendation in terms of doing self-checks anymore. I tell that to men about their scrotums as well. Just know what your body feels like, in the shower. Try not to obsess over it, but if you notice a change, you should definitely get seen.
Just to add a little bit of something to that, in terms of testicular self-exams, I find that most of my patients don't know actually, aside from something abnormal, what a testicular cancer actually feels like. And so it actually feels kind of like a rock. It's like if you feel your knuckle, that's what a testicular cancer feels like. That would just a little educational.
So as long as we're in that area, are there any medical circumstances when a vasectomy should not be performed?
When it should not be performed. I mean, the only thing I could think of off the top of my head would be a patient who maybe was on a blood thinner. That would be a situation where it might be too dangerous if they couldn't come off the blood thinner. But other than that, nothing's coming to mind. Can you think of anything?
No, I think it's
the only one I can remember is that I was unable to feel a vas in a person.
Yeah, so that can happen from time to time.
Yep.
Very rare, but in that situation, oftentimes I'll recommend that the vasectomy be done in the operating room, whereas probably 95% of vasectomies that I do are in the clinic with the patient awake, on the off chance that I need to do a little more digging, so to speak.
So the one other thing that comes up a lot in men's health is overactive bladder, BPH. And tell us a little bit about what overactive bladder is, and is there a way of telling the difference?
It can be very difficult sometimes because an enlarged prostate, so overactive bladder, it tends to be what I think of as more kind of irritative symptoms, frequency, urgency, even what we call urge incontinence or leaking urine. And BPH classically is thought of more of obstructive symptoms, weak stream, but enlarged prostate can lead to some of those irritative symptoms as well. So it can be difficult to just differentiate the two, certainly. Sometimes we'll do special tests in the clinic, such as what's called a uroflow test, where we'll have a patient urinate into a funnel, and it'll give us the velocity of their urine stream to figure out if there's actually obstruction present or not. And so that can sometimes be a way to look or distinguish between the two. Sometimes it's a matter of trying medications for one of the conditions or the other and see how they respond.
And how do the meds work?
So the most common
we have a minute, so.
Oh, okay. So the most common medication that I'm prescribing for enlarged prostate is called Flomax or tamsulosin, which works to relax the muscle fibers in the prostate and the bladder neck, kind of to open up, well, as I mentioned, the pulp of that orange. And there's also a medication called finasteride, which can actually shrink the prostate down. The overactive bladder medications are targeting more the muscle fibers in the bladder itself to try to calm it down.
Thank you very much. This has been an interesting half hour. I want to thank our panelists, Dr. Tolga Hanhan, Dr. Benjamin Marsh, and our medical student volunteers, Melissa Edgar, Michael Gutman, and Shane Johansson. Please join host Dina Klabow of Insight Counseling next week for a special mental health episode on a program on the topic of holiday stress. Thank you for watching, and good night.